What if I told you the most important MS breakthrough might not be about walking better, or fewer lesions, or even preventing relapses? What if it could actually change when MS gets diagnosed? And who gets diagnosed forever? For decades, MS diagnosis has basically been like, let's wait until your nervous system throws enough tantrums and then we'll confirm it. But what if we didn't have to wait for damage anymore? Stick around for the reveal at the end. And answer this: would you go aggressive on day one? To fully appreciate the revolutionary nature of this new approach, one must first understand the traditional method of diagnosing multiple sclerosis, a process rooted in patient's observation, the accumulation of evidence. For many years, the diagnosis of MS has been fundamentally retrospective. It has required neurologists to act like meticulous historians, piecing together a story that has occurred over time and in different locations within the central nervous system. The core tenets are known as dissemination in time, dissemination in space, meaning the disease must show new damage at different moments and in different parts of the brain or spinal cord before a definitive diagnosis can be made. It's like waiting until your house is on fire, and then deciding, yes, you probably should have installed smoke detectors. In stark contrast to the traditional model of watchful waiting, a new and compelling philosophy is gaining traction: treat early and treat hard. This approach, often referred to as an induction or early aggressive strategy, fundamentally inverts the old paradigm. Instead of starting with milder therapies and escalating only as the disease worsens, it advocates for using the most effective and powerful treatments available right from the very beginning, often after the first clinical sign of the disease. The goal is no longer to simply manage symptoms or slow progression, but to induce a rapid and profound state of remission, effectively silencing the disease before it has a chance to establish a foothold and cause widespread, irreversible damage. The biological rationale for this strategy is rooted in our evolving understanding of MS pathology. We now know that significant inflammatory activity and neuronal damage can occur very early in the disease course, even before symptoms become frequent or severe. This early phase is a critical window of opportunity. The immune system is just beginning its misguided assault, and the central nervous system still retains much of its capacity for repair and resilience. By intervening with high-efficacy therapies at this stage, the aim is to reset or reconstitute the immune system, teaching it to stop attacking its own nerve cells. For years, we've been treating MS like it's a mosquito. Now some doctors are like, no, this is a bear. Bring the tranquilizer. The widespread adoption of early high-efficacy treatment carries a fascinating and paradoxical consequence. It could fundamentally dismantle the very diagnostic criteria we have relied upon for decades. The McDonald criteria, the global standard for diagnosing MS, are heavily dependent on seeing evidence of damage spread out in space, multiple lesions in time, new lesions or new attacks. But what happens when a treatment is so effective that it prevents this dissemination from ever occurring? If we successfully intercept the disease after the first clinical event, a patient may never develop the new lesions or subsequent relapses required to meet the traditional definition of MS. The classic MRI of a person with established MS, often described as showing numerous bright white spots or lesions, may become a relic of the past for newly diagnosed individuals. If this future matters to you, tap subscribe and like. It helps more people find accurate MS science. A clean MRI would no longer be a reason to withhold diagnosis, but rather a sign that the interception was successful. Section 5. The Promise and the Proof. Early data on interceptive therapies. The theoretical appeal of intercepting multiple sclerosis early is powerful, but practice must be guided by evidence, not just compelling ideas. A growing body of data now supports the hypothesis that hitting the disease hard and early leads to better long-term outcomes. Large, definitive head-to-head trials are still ongoing, yet preliminary studies and real-world cohort data provide encouraging signals. The promise is slowly being substantiated by proof. Consistently, early use of more powerful drugs is linked to a lower risk of reaching major disability milestones. Patients started on aggressive treatment tend to have fewer relapses, accumulate less disability on standard neurological scales, and show less brain volume loss over time, a key marker of neurodegeneration. While the potential benefits of early aggressive treatment are transformative, it is imperative to approach this strategy with a clear and honest understanding of its significant risks and limitations. These are not gentle therapies. The very mechanisms that make them powerful enough to subdue the immune system also expose the body to a host of potential dangers. The decision to embark on such a treatment path is a serious one, involving a careful calibration of risk versus reward that must be individualized for every patient. There is no one-size-fits-all answer, and the principle of first, do no harm, remains paramount. The primary risk associated with most high-efficacy MS therapies is immunosuppression. However, a suppressed immune system is less capable of fighting off genuine threats. This increases a patient's vulnerability to a wide range of infections, rare and life-threatening opportunistic infections. One of the most feared complications is progressive multifocal leukoencephalopathy, or PML, a rare but often fatal brain infection. Looking ahead, the future of MS care will be defined by greater precision and personalization, moving beyond one-size-fits-all aggression to nuanced, data-guided strategies. Identifying with high accuracy who needs early intensive therapy versus who can be safely monitored. One promising biomarker, neurofilament light chain, NFL. NFL is part of the internal skeleton of nerve cells. New highly sensitive blood tests can measure these tiny NFL levels, giving a real-time signal of neurological damage sometimes before MRI shows changes. The era of passively watching multiple sclerosis declare itself through accumulated damage may be drawing to a close. We are standing at a pivotal moment, transitioning from a philosophy of reaction to one of interception. This isn't about promising a cure tomorrow. It's about recognizing something bigger. For the first time in history, we're not just managing MS. We're starting to interrupt its story. Diagnosis used to be the starting gun. Maybe one day, it'll be the checkpoint. If you found this useful, please subscribe and like. It helps this reach people making real decisions. Would you have chosen an aggressive treatment early if it meant potentially changing your long-term outcome? Or do you think early immune reset is the future? Or is that too risky? Sound off below. What if we could stop multiple sclerosis before it truly begins? What if the very definition of the disease was rendered obsolete by a radical new approach to treatment? This is not a fanciful daydream, but a profound question debated in neurology clinics and research laboratories around the world. The core idea is simple yet revolutionary. Instead of waiting for MS to leave destructive marks on the brain and spinal cord, what if we could intervene so early and so decisively that the classic signs we use for diagnosis never fully appear? This line of inquiry challenges the foundational principles we've used for generations. This is a seismic shift in thinking, moving away from a reactive posture to proactive, aggressive interception. It forces physicians to weigh the risks of powerful treatments against the slower risk of irreversible disability. This is the new frontier in the battle against MS. It is impossible to discuss this sea change in medical thinking without reflecting on the human stories that animate it. I think of a person diagnosed with MS 15 or 20 years ago, perhaps in their early 20s, full of plans and ambitions. At that time, the standard of care was to wait and see. They were likely started on a moderately effective injectable medication, a therapy that was revolutionary then, but now often failed to halt the disease. Now, imagine an alternate timeline for that same person after their very first symptom, an initial bout of optic neuritis, or tingling in their hands. They are given different counsel, told about high risk of future disability, offered a powerful, one-time immune resetting therapy, or an early course of a high-efficacy biologic. They accept significant short-term risks. Years later, their MRIs remain stable. They have no further relapses. The fatigue is gone. The cognitive fog never descended. The central question is no longer just, do you have MS? It's evolving into, what is your risk of developing MS? And can we prevent that from happening? It transforms the patient from a passive observer into an active participant in a strategy to preserve neurological health. Ultimately, this could lead to the creation of entirely new diagnostic categories and guidelines. We might see classifications like pre-MS or at risk for CNS demyelination, with specific treatment protocols attached to each. Finally, we must confront the realities of access and equity. These advanced therapies are extraordinarily expensive. Availability can be limited by insurance coverage, geography, socioeconomic status. The prospect of a two-tiered system is a serious ethical concern. The promise of a better future for people with MS must be a promise for everyone.